Um, Picture is aplastic anemia and polycythemia. The learning objectives of this picture are as shown. Aplastic anemia is the syndrome of chronic primary hematopoietic failure and pancytopenia. This is a disorder in which the bone marrow it fails to form RBCs, WBCs, and platelets, and therefore there is deficiency of all these cells. There is pancytopenia, there is anemia, neutropenia, and thrombocytopenia. Causes of aplastic anemia include toxic chemicals, radiation, various drugs like chloramphenicol suppress the bone marrow, viral infection, especially parvovirus B19, it suppresses the bone marrow, autoimmune disorders, and pregnancy due to various hormone changes and because the body is more prone to viral infections during this period. Aplastic anemia can also be caused by genetic disorders, and these include Fanconi anemia and short telomeres or telomere defects. Fanconi anemia is a rare autosomal recessive disorder in which there are defects in a protein complex that is required for the repair of DNA. Bone death suppresses early in life, and this disorder is also associated with multiple congenital problems like hyperplasia of kidney, spleen, and skeletal abnormalities. Other disorders that is an important cause of aplastic anemia is short telomeres, in which there are defects of telomerase, or there is excessive stem cell replication that exhausts the cells age rapidly, or this can be due to unknown cause, idiopathic. Telomeres are the end parts of the chromosome, and they are maintained by the enzyme telomerase. Normally, only stem cells have this enzyme. The mature cells, they do not have this enzyme, and that is why they age with each DNA replication. In case of short telomeres, the telomeres on the end parts of the chromosomes are shortened early, prematurely, and therefore the stem cells they also undergo premature aging. Regarding the pathophysiology of aplastic anemia, is not completely understood why this disorder occurs. However, there are two major etiologies that have been suggested. One is extrinsic immune-mediated suppression of bone marrow progenitor or precursor cells, and the other is the intrinsic abnormality of stem cells. Immune-mediated suppression of marrow progenitor cells or precursor cells. This happens when the stem cells they are antigenically altered or changed by exposure to various drugs, infectious agents, or environmental carcinogens, or environmental insults. This starts a cellular immune response, the body's immune system is activated, and therefore the CD4 cells they are also activated, and they suppress the bone marrow stem cells by damaging them. The T cells they also produce cytokines, interferon gamma, and tumor necrosis factor that suppress and kill the progenitor cells. Initially, the stem cells they are altered by an extrinsic stimulus that may be some environmental insult, maybe an infection, or maybe a drug. Then the immune system gets activated, and when the T cells they are activated, they secrete various cytokines to damage the stem cells in the bone marrow. Here you can see this is a stem cell, and after it has been exposed to various environmental insults, it is genetically altered and it expresses new antigens. And these new antigens they are detected by the body's T cells, and therefore an immune response is generated, and this results in bone marrow suppression. Also, when stem cells they are genetically altered, They intrinsically become abnormal and their proliferative and differentiative capacity reduces. And this is another cause that leads to aplasia of the bone marrow. Regarding the intrinsic abnormality of stem cells, this is because of various chromosomal abnormalities or short telomeres that was discussed the previous slide. Short telomeres can be the result of telomerase defects. They can be extensive replication of the stem cells or they can be idiopathic. DNA damage results in injury that limits the proliferative capacity of stem cells. Aplasia can later on transform into tumors, myeloid tumors. What we find is aplastic movement. Aplastic has the name indicating there will be absence of any group of the blood cells, RBC, WBC, as well as the platelets, all are reduced. There is pancytopenia, there is reticulocytopenia in the normal condition. When there is anemia, the body compensates by producing more and more reticulocytes. However, in this case, as the bone marrow itself is suppressed, therefore reticulocytosis cannot occur and the count of reticulocytes in the peripheral circulation is also low. The bone marrow shows a markedly hypocellular picture. Here is a picture of bone marrow that is showing the replacement of progenitor or precursor cells in the bone marrow that have been replaced by fat cells. So the marrow is showing a hypocellular picture containing mainly fat cells, and in between the fat cells we can see some of the hematopoietic stem cells. This is a picture showing the bone marrow aspirate. You can see the normal bone marrow, which is showing cellularity. Then there is a picture of leukemia, which is a malignant tumor of blood cells. And here you can see that the cellularity has increased, this is hypercellular. And you can compare it with the aplastic bone marrow, which is showing the hypocellular picture. The game bone marrow biopsy comparing the normal bone marrow showing hematopoietic precursor cells and the bone marrow with less number of fat cells. And the other picture there is aplastic anemia and hypocellular picture with more of fat cells and less of the hematopoietic cells. Aplastic anemia has a primary progressive onset. It can occur at any age and either sex may be infected. There is anemia, which leads to progressive weakness, pallor, and shortness of breath. There is thrombocytopenia, which leads to fatigue and bruises. And there is neutropenia, which leads to frequent infections. There are two other entities that we'll be discussing in this lecture: pure red cell aplasia and polycythemia. Pure red cell aplasia is a primary marrow disorder in which only the red cell progenitors are suppressed or absent. Also, pure red cell aplasia include infections, drugs, autoimmune reactions, and malignancies of the blood cell. An important cause of red cell aplasia is parvovirus COVID-19 infection. This virus infects and destroys the red cell progenitors. Normally, this infection clears within 1 to 2 weeks with transient aplasia in individuals whose immune system is competent. But in immunosuppressed people, the infection persists and leads from the red cell aplasia along with pneumonia. In cases of myelocytic anemia, this is the disorder in which there is bone marrow failure, and this is caused by replacement of the normal marrow elements by either a malignant tumor or by fibrosis in the bone marrow. Mile means marrow, and this is shrinkage of the bone. So there is shrinkage of bone marrow either because of the tumor or because of fibrosis. The Causes may be neoplastic, like metastatic carcinoma or neurological malignancy, or it may be due to non-metastastic causes, which includes granulomatosis diseases like tuberculosis and fungal infections, and fibrosis due to other causes. Regarding the morphology of myelofibrosis, they will be due to erythroblastosis, which means there will be abnormal release of nucleated precursors of red cells and white blood cells in the peripheral smears, as you can also see in the picture that is shown. The precursor cells of the red cell line and the white cell line, they will be seen in the peripheral circulation. Here, dog-shaped red cells are seen. These red cells are deformed when they pass through the fibrotic marrow, and there is also distortion of bone marrow and fibrosis. Now coming to polycythemia. Polycythemia means abnormally high red cell count with corresponding increase in the hemoglobin. Polycythemia may be relative or it may be absolute. Relative increase occurs when there is hemoconcentration due to decreased volume of the plasma. And absolute increase occurs when actually the total number of RBCs increase in the blood. Active polycythemia may be due to dehydration, vomiting, diarrhea, excessive diuretics, and stressful conditions. In all these conditions, plasma volume is decreased, so it appears that the number of red cells has increased, and actually it has increased. In cases of absolute polycythemia, it is further divided into two types, primary and secondary. In cases of primary polycythemia, this occurs when there is an intrinsic abnormality of the hematopoietic precursor cells. Erythropoietin is low in this condition. In secondary absolute polycythemia, the red cell progenitors, they are normal. They actually respond to increased levels of erythropoietin. In secondary polycythemia, levels of erythropoietin are high. Primary polycythemia can be due to two important causes, polycythemia vera and inherited erythropoietin receptor mutations. The rare ones. Polycythemia vera is a myeloproliferative disorder that is associated with mutations in the JAK2 gene that eventually lead to erythropoietin independent of red cell progenitors. A normal condition, the red cell precursor cells, they require erythropoietin to form mature RBCs. But in polycythemia vera, because of mutations in JAK2, the red cell progenitors, they become independent. They do not require erythropoietin to proliferate. Causes of secondary polycythemia include lung disease, high altitude living, cyanotic heart disease, erythropoietin secreting tumors like renal cell carcinoma and beta cell carcinoma, variants of hemoglobin having high oxygen affinity, or when oxygen will not be released from hemoglobin. There will be hypoxia in tissues, and this hypoxia will stimulate erythropoietin level will increase in the blood and lead to secondary polycythemia. Then homozygous mutations in the VHL gene, they can also lead to secondary polycythemia because they stabilize hypoxia inducible factor 1 alpha. When this factor is stabilized, it stimulates the transcription of erythropoietin gene. Erythropoietin gene will encode the protein erythropoietin, and erythropoietin will increase, resulting in increased proliferation of red cell progenitors. On laboratory findings, there is increased hematocrit, the red cell mass increases, platelets and white blood cell count may also increase. This is a table. You can see the differences between primary and secondary polycythemia. Primary polycythemia is basically a condition due to abnormalities in red blood cell production, while secondary polycythemia is a condition that is caused by factors like hypoxia, sleep apnea, tumors, and there are high levels of erythropoietin in secondary polycythemia. Along with RBCs, other cells in the blood like white blood cells and platelets are also placed in primary polycythemia where while in secondary polycythemia, only red blood cells are increased. There are JAK2 mutations in primary polycythemia, whereas in cases of secondary polycythemia, inherited mutation to hemoglobin gene producing hemoglobin variants may be seen. Diagnosis of primary polycythemia depends on hematocrit tests, hematocrit testing, hematocrit increase, genetic testing is also done, which is JAK2 gene is mutated. And in cases of secondary polycythemia, along with the hematocrit test, genetic testing for variants of hemoglobin having higher oxygen affinity, along with test for erythropoietin hormone is done, and erythropoietin will be high in case of secondary polycythemia. For polycythemia, therapeutic phlebotomy is done, which is just like blood donation, and this removes the excess red blood cells present in the circulation. This is all. Thank you.